I made you a co-host, so you should be able to share your screen.
Cool. All right. How's everybody doing? Just I guess just to clarify, this is mostly M1s and M2s, right?
Yes.
Cool. Okay. So thanks for having me. Um, Speaking to the leaders of the interest group, I guess the objective of this lecture or this talk, I'll just I'll talk to you guys a little bit about what I do, and it's going to be more case based. I think it's more fun kind of to show cases, and then once you have the questions in your head from seeing the case, I can explain what we do, how we tackle the problem, what we think about, what our day to day is, and obviously, these things are a lot more fun in person. I'm up in New York City, and I wasn't sure what my OR schedule was going to be today, so if anyone has any questions, I don't know exactly how you raise your hand or interrupt or anything, but feel free at any point if you're curious. Just kind of, you know, don't be shy. All right, so let's see here. All right, you guys can see something that says cases in orthopedic adult reconstruction. Let's see. There we go. Okay. By the way, that's how you spell orthopedics. Don't spell it with just an E. And what I'm going to do is just there you go. Okay. A little bit easier that way. All right. So this is the first case. This is a 56-year-old female. And as an orthopedic surgeon, almost you're going to specialize most likely in something. But you may specialize in joint replacements or hand surgery or pediatrics or whatnot. But for the most part, you're going to always have people come in that are going to tell you about any part of their body that's bothering them. And you're not, you may wind up super specializing in a certain field, but as an orthopedist, you're pretty much an expert on the entire body. So this is a 56-year-old female. She came in and she's complaining of pain in her leg, and this is an X-ray of her knee. I don't know if anybody here wants to take a crack at looking at this X-ray and seeing if they think there's something wrong. Let's see. Does anyone want to jump out and volunteer and take a crack at it? Don't be shy. Who's leading this meeting again?
I am, I
All
guess.
right, there you go. Okay, go ahead. So what do you think? What's this an X-ray of?
It's an X-ray of the patella that we're looking at least in this bottom
Can
right.
you see my mouse?
Yes.
Okay. Can you also see the chat that I have on here? You can.
No, I don't
Okay,
think
you can
so.
only see the slides. Okay, cool. All right.
Yes.
So this is so what do you think? What bone is this?
That's the tibia.
Perfect. Okay, and then what about this one?
That's the femur.
Perfect. And what about this little guy?
The fibula.
Fibula. Perfect. Okay. And then what about this bone?
It's the patella right there, I think.
Awesome. All right. So that's the first part of looking at an X-ray. Good job. I'm not going to grill you, I promise. So this is an X-ray of a knee. All right. We would call this a 4-view X-ray of the knee. So this over here is an AP. This over here is also an AP, but it's a special view called a flexion view, PA flexion view. So the beam is coming from the forward and going to the back. This is the back coming from the front. This is a lateral, meaning you're looking at it from the side. And then this over here is a view of the patellofemoral joint called a merchant view. All right. Or a sunrise view is another way of looking at that joint. So basically, if you look at this X-ray, this is a knee that has arthritis, or actually arthrosis is the right term, because arthrosis means that there's destruction of the joint space. There's 4 things that we look for. There's joint space narrowing. You could see that this black space where there would normally be cartilage, there's none on this side over here. So there's joint space narrowing, this really dense white stuff, that's sclerosis, subchondral sclerosis. This little bump over here, that's not normal. That's an osteophyte. Okay. And then there's also something called subchondral cysts, which you can see over here. So those are the 4 signs of of arthrosis. And then the pain that comes from it, arthritis is, a very common diagnosis. So this is someone that comes in and they have some pretty bad knee pain. They have knee arthritis. And, as an orthopedist, you wonder like what can we do to treat this patient? All right. There's a couple things. Number one, we can give them some pain medicine. And when I say pain medicine, we mean anti-inflammatories, ibuprofen, meloxicam, diclofenac. Those things will help, but they won't solve the problem. They'll kind of keep the inflammation at bay, and they're a pretty good first line treatment. Some people are very happy with this. The second thing that we can do, say that doesn't work, is we can give them an injection, a steroid injection. There's also injections of hyaluronic acid. Steroids, hyaluronic acid, they both have a similar effect, meaning that there's no study that shows that one is better than the other. You may be watching TV and see these ads for this magical gel that people inject and it replaces the cartilage. None of that's true. The hyaluronic acid is more of a lubricant, whereas the steroid is a very potent anti-inflammatory. Either way, again, it's a band-aid. It doesn't really fix anything. So the question is, how do you actually treat this? And the answer is surgery. Okay, so this is something that we would do, something called a total knee replacement or a total knee arthroplasty. And that's what a total knee arthroplasty looks like. Okay. So right over here, you can see that this is the femoral component. The femoral component is placed. This is the tibial component. This space here, or lack of very high, very dense material, that's actually plastic, something called highly cross-linked polyethylene. And then this over here is a resurfacing of the patella. So there's four parts to this, right? Femur, tibia, plastic or polyethylene, and then the patella. So this is a total knee arthroplasty. So now here's another case. Let's see. Nicole, looks like your co-host also. So you get to take a look at this one.
Okay.
All right. So what do you see over here where my mouse is?
The pelvis.
Perfect. Awesome. Okay. So this is a pelvis X-ray. All right. So this is whenever you look at an X-ray, if it's an AP, meaning that the beam is from anterior to posterior, the image is flipped, meaning that even though you're looking at this, it looks like it's the patient's left side, it's their right. They're facing you. Okay. So patient's right hemipelvis, left hemipelvis. Okay. So what bone would you say this is over here?
The femur.
Perfect. Okay. Now we'll say that this is really your innominate bone, but do you know what part of the pelvis this is right over here?
No.
Okay, this is the ilium. All right. This is the ischium. This is your pubis. And then this kind of little demarcation over here, that's your sacroiliac joint. Okay, so this is your sacrum. And then this is starting to be your spine. So this is L5, your lumbar 5 vertebrae. Okay. Now, if you look at these, you're off the hook, Nicole. Good job. So if you look at this X-ray, when you're looking at the pelvis is a structure that has two sides, obviously, the mirror images of each other. Okay, so if you look at this X-ray, you can say, okay, here's my midline, and then everything that's on this side should be on this side. So you can compare the two. All right, now we're going to look at the right side, because the right, remember, it looks like it's the left, but it's the patient's right. We're going to look at the left, or your left of your screen, the patient's right hip. Okay, this is the acetabulum. This is the femoral head. This is the femoral neck, the greater trochanter, the lesser trochanter, the metaphysis, and then this is where the diaphysis starts. Okay. Now, if you look on this side, this hip does not look like this hip, right? This hip is much less symmetric. So round, not round. Space. When I say space, I mean dark white, kind of, lighter. A light on X-ray means dense. So dense, not so dense. That's called joint space. That's where cartilage is. And you could see that there's none on that side, right? And then you see some irregularity here. Okay. What that actually is that's a big osteophyte. That same thing that I pointed to, let's see, what I pointed to over here, this same thing, this osteophyte, it's the same type of biologic process over here on the medial wall of the acetabulum. Okay. This is a lateral view. So just to reorient you here, this is the patient's left side. This is the greater trochanter looking at it from the side. That's this same structure over here. Okay. This is the femoral head. Same thing that we're looking at over here. And then this is the acetabulum. And you could see here that this semi-round hole or round ball is not fitting into this socket. And the same thing's happening over here. So we call this arthritis with subluxation. Okay, so you could see that here the acetabulum's kind of covering the ball, but on this side it looks like the hip wants to go up and out. Okay, that's a sign of end stage arthritis. And then this osteophyte over here is also pushing the joint out. Okay, so those two things should say that this patient has significant left hip arthritis. And then you would say, like, what are these images over here? This is a lateral of the spine. And when you get into advanced joint replacement, it turns out that the dynamics of your hip are affected by your spine. So even though we're joint replacement surgeons, we pay attention to the spine and we see how much the spine moves when the patient sits and stands. And that tells us the dynamics of what their hip joint's going to undergo and how we place our components. So there's a lot of physics involved in that. So now you're like, okay, I understand this patient has arthritis and it's basically the same treatment options, pain medicine, physical therapy, injections. But the truth of the matter is, the only real fix for this patient is surgery. And what we do here, so this is kind of the everyday, like what is my day or what is a joint replacement surgeon's day? We see this patient, they come in, they're like, oh, like my hip really hurts. I can't put my socks on. I can't get out of the car. I can't walk for more than a block without a significant amount of pain. I want to get my life back. So, we discuss surgical options with them. And then if they agree to surgery, then we have to plan everything. So surgery is obviously very complicated. It's someone is trusting you. They're laying down on the table and they're going to sleep and they're allowing you to operate on them. So the amount of planning that goes into this is very, very, I guess intense is a good word, but it's very meticulous. So this is called templating. And what we do when we template is usually there's a bunch of different programs that do it, but you get a pelvis x-ray. And what you do is you use technology to place your components that you're going to do your arthroplasty with where you think they're supposed to go. Okay, so this is the acetabular component. And then you also place your femoral component, which is your femoral stem, where you think it's supposed to go. And then what you do is you measure how long patients' legs are, because when you do a hip replacement, you can make their leg longer or shorter. Okay, that's one of the consequences of surgery. So what you want to try and do is you want to try and bring the leg to as close to anatomic level as possible. Okay, so in this template over here, this patient, we placed the acetabular component, we placed the femoral component, and this patient had a very strong external rotation contracture, so it was a little tough to template. But you find out how your surgery is going to affect them, in what way, and then when you do the surgery, hopefully your surgery looks pretty similar to your template. Okay, it's never exact, but it gives us a pretty good idea. All right, so I'll stop there. Any quick questions?
Yeah, Dr. Minona.
Sure.
So about the hip replacement, is there ever a case where it's sort of like totally off, or like there's some sort of miscalculation and you sort of find out while you're doing the surgery? And if that happens, what's your kind of next step?
So what do you mean by off?
Like it just doesn't fit the patient, or it's at the wrong angle or something.
Like the components that we think we're going to use are not.
Yeah.
Is that kind of what you're saying? Okay.
Uh-huh.
So that's a good question. So basically that's actually why that's actually a very good question. So that's why we template. Okay. What templating does is it gives us an idea of what the ballpark of our component sizes should be. So this component over here, the acetabular component, it's measured. So it's basically a hemisphere, a half a ball, and the diameter of that ball can change. And most companies, there's a number of companies that manufacture these that we use, but it goes in 2 millimeter increments. So every 2 millimeters, there's a different size. So you can imagine there's a lot of different sizes that you can put into patients. And what templating will do is it will tell you, like, when I forget what this patient was. I think they were a 50 millimeter cup. When I start to use my reamer, if I ream and I think that I'm done at a 48 or a 50 or a 52 or even a 54, I know I'm in the ballpark. But if for some reason I was at 60 and, things aren't going well, then that's a red flag. The other thing that can happen is if things seem not to be fitting, it usually means that there's challenges in anatomy or there's some other type of problem that you can't see. And there's a number of algorithms and checklists that you can go down to make sure that you're not hurting the patient. But, and then some patients are just very difficult surgeries. But it's a good question. And the answer to the short answer is templating like this, or using robotic technology also helps. Okay. So what is before we get into that, did that answer your question?
Yes, thank you.
Okay. Any other ones? No? Okay. All right. So what is joint replacement? So, joint replacement, it's a little bit of a misnomer. People think, when they get a total knee replacement that you're basically like doing a partial amputation and rebuilding their leg. And that's not really true. The amount of bone that you take when you do a knee replacement, the better term would be a knee resurfacing. And then it's really the same thing for your hip replacement. The only thing that you're really removing is just that damaged femoral head. And then you're just kind of shaving a little bit of bone from the acetabular. So when you do a hip replacement, you cut the femoral neck, and you take this part out because that would die. And then you ream. It's a circular saw, basically. Not a circular saw in the sense that that you would think of at Home Depot, but it's a rotating ball with blades on it, and you make this a hemisphere again, and then you just take out the inner cancellous bone of the femur and place an implant. So it's not quite but it's a much more bone preserving procedure than people think. So this is a total knee replacement implant. This is a Stryker's Triathlon. This over here is a total hip replacement. So there's the stem there. That's what it looks like. This is a Smith & Nephew's Polar stem. And then this is what a cup looks like. And then this is a dual mobility head, actually. This over here is a component of joint replacement that a lot of surgeons now are using, called robotics. So this is Stryker's Mako robot. Okay. There's a couple of different companies that make different robots now. Stryker makes Mako. There's the Rosa. There's the Corey. There's what else is there? There's a couple of DePuy just came out with one. But the truth of the matter is, robotics, and then I'm sorry, there's also navigation, there's ortho-align, there's IntelliJoint. There's a lot of different technology that's used to make surgery much more accurate. So you can see over here, this is a surgeon using the Mako. And what the Mako does, it's not like, you just punch into a computer and it does a surgery for you. What the Mako does is the Mako uses a CT scan beforehand, which you can see over here. And it basically templates, just like we were looking at before, it templates based on a CT scan where your components are going to be. And then when you do your surgery, you drill arrays into the bone that are static, that move with the bone. So the machine has a CT scan in its data bank. It has these arrays as fixed points, and then you use a probe to basically verify where all those points are on the bone. And then that saw makes sure that the cuts that you make correspond with your template. So it's super accurate. And then it's something very, very similar over here. This is the Mako templating out an acetabulum for a hip replacement. So this is from the Hip and Knee book. This is actually written by former Robert Wood resident. But basically, you can, just to show you this, these are the cuts that you're making on a knee when you do a knee replacement. So you can see it's really not a whole lot. your femur basically looks like a box afterwards. And then you take a little bit of bone, like 9 millimeters or less, off of the tibia. And then the component, you can see this is how the component fits onto the femur. Keep that image in your head. And you could see that's kind of the same cut over here. Okay. So that's how a knee replacement works. And then in hip replacement, same kind of resurfacing type of concept. The acetabular cup is placed where you ream. Right over here, that's the acetabular cup. And then the femoral stem is placed. You do something called broaching, where you prepare the femoral canal and then you put the femoral stem in. And then once both those things are done, then you find a head. Well, you don't find, but you trial a head that fits, and then you reduce, meaning you put everything in place, and then that's it. So that's the basic concept of hip replacement. But what this does is it restores the joint mechanics, it restores the anatomy, the arthritis is gone, and the patient is able to ambulate the same day, and they're able to, after a short period of like rehabilitation, they're able to get back to their normal life, hopefully. Okay. So before I go into, specific cases that are a little bit more complicated, we can stop for questions if you guys want.
Yeah, Dr. Minola, I have one. So regarding the implant, is there any need to do any bone grafting, like just to ensure that like the implant is stable, or is it just planned so that when the implant goes in, that it's going to be flush with the bone, and so you don't need to really worry about like any instability there?
Yeah, so there's two different ways that joint arthroplasties they achieve their fixation. One is cement. So in total knee replacement, this is a cementless knee, but before you put this implant in, when you're done, after you made all your cuts and you prepare the knee, you coat the implant with methyl methacrylate cement. And then you also put cement into the canal itself. And that cement binds to the bone, and then the cement also binds to the implant. The second way, and you can also do that with hip replacements. Most of the time you do it with just the femur. And you do that usually in people that are older and have more poor bone quality. The second way is press fit. And press fit means that the cut is made, the implant is placed, and then the implant has a metal, a tantalum metal, which is a highly porous coated, very advanced composition on the implant that makes it very sticky. And sticky meaning not in the sense that you would think about it like hot and gooey, but more there's a very rough friction, and that implant surface is also designed for the bone to grow into it. So it's very stable when it goes in, and then eventually the bone like integrates and fuses into it. And that's what this knee implant is, and that's also what this hip replacement, it's coated with hydroxyapatite. So those are the two. And then also for the acetabulum, every once in a while, the acetabulum is also coated in this, but every once in a while we'll put screws into the pelvis for added fixation. So that's how you get your fixation.
Thank you.
I just have a really quick question. When you're doing like a hip replacement, let's just say the patient's a bit younger than most, like in their 30s, is there a certain like are they able to keep that one hip replacement throughout like the rest of their presumed life, or would they be like needing another eventually?
Sure. Great question. So what's really cool about orthopedics is it's constantly being improved by improvements in technology. And it used to be the case that, I don't know if you remember me saying there were 4 components to the knee replacement. There's femur, tibia, plastic, polyethylene, and then the patella. And then in a hip replacement, the components are femur, femoral stem, femoral head, acetabulum, and then that same space is polyethylene, that plastic. So there's also plastic, and the interface is usually ceramic or metal on plastic. So to answer your question, in the last 15 years, there's been an advancement in the plastic. It's called highly cross-linked polyethylene. And we figured out the right way to both make and preserve and package and maintain the integrity of this plastic so it doesn't oxidize and so it doesn't break down and it doesn't wear out. It's very, very good. And at this point, it used to be that with the old plastic, after about 10 to 15 years, the plastic would wear out because this head would rotate around and patient would walk and there would be this repetitive micromotion and this wear would happen to this plastic. And then eventually the plastic would wear out and then it would be metal on metal. And the metal would kind of grind and there would be metal particles and ions and a big inflammatory process and all the stuff that you learn in basic science would start happening. And then that inflammatory process would start eating the bone and the pelvis, and then the cup would get loose. And this would happen very often. So patients would need to get revised. Now, with that new technology, it doesn't happen. So the short answer to your question is if the hip replacement is done very well, meaning the components are in the right place and it doesn't get infected and there's no trauma, then yes, it can last for a very, very long time. In their 30s, we're looking at this plastic now after 20 years and there's virtually no wear. So, yes, it can last a long time.
Thank you so much.
Sure. Any other questions? Okay. So now comes the fun stuff. Now this is what I do. My training is to do joint replacements, but I also did a trauma fellowship. And orthopedic trauma is really bad fractures, complex fractures, stuff around the pelvis, but also, sometimes, people have hip replacements and they get into trouble. When I say trouble, I mean not they did something wrong, but something bad happens to them. So over here, this is a patient that's relatively sick guy, and you can see 3 x-rays over here. Okay. Does anyone else besides the 2 people that I called on want to take a shot at looking at this x-ray and tell me what they think is going on? Let's see, Sydney.
I can give it a shot. So
I'm only asking because it says co-host next to your name. So
yeah. So in the middle x-ray, it looks like on the left hip that's something is sticking out.
Something's sticking out. Okay.
Yeah.
Okay. Would you say maybe it's broken?
Oh, yes.
Okay. I would agree with you. All right. So let's look at this x-ray over here. So this is the one you're talking about, right?
Yeah.
Okay. So what bone is this, would you say?
The femur.
Good. All right. So that's the femur. And then this is the pelvis, right?
Right.
Okay. Now these components are the same ones that we were looking at. So this is the acetabulum, this is the femoral head, and this is the stem. Okay. Now, to identify a fracture, this is cortical bone. That's the cortex, the hard stuff. And then this is cancellous bone, or the canal. Okay. And you can see that they're different densities because they're different colors. And if you trace this up, you see how this line stops and then it goes all the way out here. That thing that you're seeing sticking out is actually the medial calcar, or the medial aspect of the proximal femur. All right. So this guy fell and broke this part of his femur. And then also this is the greater trochanter. So the greater trochanter broke. Okay. So this stem is just kind of floating around in here. It's not doing anything anymore. This guy can't bear weight. Okay. So now what do we do? Like, as an orthopedic surgeon. Now, again, this is kind of going back to what do we do? First thing you have to do is you have to diagnose it. Okay. And we have a system for identifying these types of fractures, something called the Vancouver B fracture. We figure out if we want any additional imaging, whether we want a CT. Then we have to figure out what implants this person has in there. Okay. Because when we go in and do surgery, we need to know what kind of cup this is and stem this is. Not really in this case knowing what the stem is because the stem's coming out, but we need to know what cup it is, because different companies make different size plastic or polyethylene that accept certain size heads. So there's actually a lot of planning to do with these things. And then we figure out whether or not we want to put in a new stem, a longer, newer stem, or a plate and screws. And then we go through, plan A, plan B, plan C. This is what I planned for this case. And all of these plans have a number of implants, a number of instruments, OR setups. So there's a lot of planning for these. It's very technical. If you're someone that likes to plan, then this is a good job for you. And this is a surgery that we did. Okay. We kept the cup didn't need to move. And we did something called a revision total hip arthroplasty, where we put in a long stem. You could see how long this stem is compared to the last one, right? And this stem, so to answer the question before about fixation, this stem is a diaphyseal engaging stem that gets its fixation via press fit, okay? This stem is basically wedged into the bone over here and will bond, and the bone will grow in. And then these cables over here serve to reduce the fracture, okay, to restore biomechanics. And then we reduce the hip. And then this patient's actually allowed to bear weight afterwards. This is called a revision total hip arthroplasty. Here's another one. So looking at, the pelvis x-ray again, okay, not so bad. Arthritis. Okay, so this lady comes in, say you're her physician, and you establish a relationship with her. I forget how old she was. I think she was like in her mid 80s, but she's pretty active. And she said, doc, my hip really hurts. I want a hip replacement. So now you put yourself in that situation. She's your patient. You agree to do surgery on her. She wants a total hip replacement. Okay. You book her for surgery. You get all the x-rays that you want. This is something called the standing long length AP film to see the alignment of her limbs. You take a look at her spine like we were talking about before. Okay. And then you get a phone call and she fell and she has something called a reverse obliquity intertrochanteric fracture. So you can see this fracture over here. That femoral, so you see the femoral head and neck relationship on her right side. You can see on her arthritic side, she broke her hip. Well, actually not broke her hip. She broke her her femur. So that's like a reverse obliquity / subtrochanteric femur fracture. So now what do you do? This patient came in, they're your patient, and now they can't walk. You can't really do a total hip replacement for this type of fracture. Okay. You need to do a good total hip replacement. You need your abductor mechanism. Okay. Meaning that your abductor muscles, like your gluteus medius and minimus, attach right over here. They start over here and they attach here. That's how you bring your leg up and how you walk. Okay. This needs to be unitized to the femur for you to have, an intact gait. So this patient actually can't have a hip replacement right now. They need something called a cephalomedullary nail, or a long femur nail. Okay. So this is a Stryker gamma nail. You could see the bones reduced, and the patient can bear weight and she can walk. But the issue is she still has arthritis, right? Like she's back to where she was pre-op, even though it's post-op. So now what do? You go back to templating, and because you have this long implant in here, you actually need to place, and she also has this fracture. You don't want to put a normal hip replacement that will stop here. Just kind of gave it away over there, but you want to put a hip replacement in that's going to go a little bit longer to bypass that fracture. And that's what we did. So that's a Smith & Nephew redapt and polar cup.
Steve, let me stop you for 1 sec. That's an incredibly complex case and technically excellent. Just to go back to what you said before, when you talk about a fractured hip. So tell us why that's kind of a misnomer and how you can apply that to the rest of the body when you're referring to a joint versus the name of a bone. Because that comes up in lay practice.
Sure. That sounds like Dr. Cott.
Yeah, it is.
So I think what Dr. Cott's asking is, so what happens a lot in orthopedics, and I'm sure you know the layperson will say like, you know, oh, my grandmother fell and she broke her hip. Um, the hip joint specifically is the acetabulum, like we were talking about, and then the femoral head. That articulation is the hip joint. A hip fracture can mean, and you know, in the orthopedic community versus the lay community, a hip fracture can mean a fracture through the femoral neck, a fracture through the basicervical area right over here. Okay, and we distinguish those because the blood supply is a little different. We don't have to necessarily get into that. It can mean a fracture here through the intertrochanteric area. And then it can also actually mean a fracture right below or right at the level of the lesser trochanter, which is a subtrochanteric fracture, which we see over here. So if we say this lady fell and broke her hip, it can mean all four of those things. How you treat them is also a little bit more in depth. But depending on where you break your femur, like I was saying before, if you break it from here that way, meaning here, 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 you can do a hip replacement and it will do well. If you break it from here, 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 you actually have to fix it because that abductor mechanism won't be intact and the patient won't do well with a hip replacement. Okay. Dr. Cott, to your idea, was that the question that you were asking?
Yeah. But I think that, the take home point too is that, it's impossible to break a hip, right? You could dislocate your hip, but actually what's happening is you're breaking your femur. Or what I see a lot is, people say, oh, I broke my wrist. Well, no, you broke your radius, but it's, the common bone, right next to the wrist. So just to, have the appropriate terminology as
Absolutely.
to what's actually happening, because patients will always stop you at the most basic thing and, say, well, what did I break? What is this? And, you got to go through it. So, yeah, that's an excellent explanation.
Yeah. And as I was saying before, just, kind of to recap, when we talk about joint replacement is actually a misnomer too. I think I said this earlier in case anyone came in later. Like a total knee replacement isn't a knee replacement, it's a knee resurfacing. You're not taking a ton of bone out. And the same thing when you do a hip replacement, the amount of bone that you take, like people think that you're like, bringing in, if anyone's ever seen the movie RoboCop, like that's not what you're doing. The amount of bone preservation that we do is actually, pretty remarkable. Okay, so we did that. So she did well. Okay, so here's another. Now this is actually, I put these two together because there's more than one way to skin a cat, and that's what's cool about orthopedics. Sometimes you may have a fracture that looks the same, but it can be treated differently, or there's subtle differences that dictate that it's treated differently. So you're not just a technician, meaning we see something's broken and we just go to work. There's actually, attention to detail and meticulous planning are very important. So this is a patient, she's 79, and she fell from a standing position. And this is very subtle, but it's actually something that's, a big problem. So if you look over here, this is an x-ray of someone that had a hip replacement 2 years ago. Okay. So this is the femoral stem right over here. This is Smith and Nephew polar stem. And then this is the cup. Okay. And then this is the head. And then if you look over here, I would say to the untrained eye or even to the novice person, they would say this looks like a pretty normal x-ray. But if you look over here, if you look on the lateral aspect of the femur, trace it with my cursor over here, you can see there's a fracture right over here. Okay. And then also, if you look very subtly, there's also a fracture right over here. So this patient has a fracture right at the level of their femoral stem. Okay. Now, going back to the other x-ray, I'll just show you to remind you, the person that had a periprosthetic fracture, it was very easy to see this fracture. Okay. And you could see almost even to the untrained eye, this stem is kind of just floating around in there. And you can imagine putting weight down, your vector of force is going this way. You can imagine your weight going down and this stem is not going to do its job. Now, when you go to this patient over here, you don't know if this stem is still fixed or not. Okay. And what you have to figure out as an orthopedic surgeon is whether or not that stem is fixed, meaning that that it's still wedged into bone, it's still structurally sound, and the patient can still put weight on it, or if it's loose and needs to come out. And that's what we did over here. We got a CT scan, and you could see the fracture right here. You could see the fracture right over here. And when we did surgery, we found out that the stem was stable. So we did something called the periprosthetic femur open reduction internal fixation. So what we did over here, you can see the staples. We did an approach posteriorly. Okay. We identified the fracture site, and then we put a plate right over top. And these are screws below the fracture site, fixing the plate to the bone. There's screws up here above the fracture site, fixing the plate to the bone. And then there's also, these are cables that are made of titanium. I'm sorry, stainless steel. This is a stainless steel cable that are reducing the bone to the plate. And this will stay here. So this is another way that you can fix a periprosthetic fracture in the right setting. So as our joint, so basically the point is there's more than one way to treat these problems, depending on what your specialty is, depending on what the presentation is. So it's a job that, you're constantly thinking, you're constantly figuring out the best way to treat the patient, using the latest technology, using the best tools in your armamentarium to kind of, to do that. And then this is the one that I was going to end with, because this is the coolest one, I think. So this is a patient that, if you look at this pelvis x-ray, let's see. Andrew.
I'm here. How are we doing?
All right, Andrew. What would you say is wrong with this pelvis x-ray? Just take a stab at it.
I think the biggest thing is the height of the acetabulums are shifted. So the one on the left is much higher than the right. And I think we're seeing a lot of arthritis on the right hip.
Okay, perfect. All right, so that's a good point. So this is a pelvis x-ray that shows that one leg is really not where it's supposed to be. So this something's very wrong right there, right? But then there's also arthritis on this side. So I'm gonna tell you that this guy came in complaining of this side. All right. It's not uncommon to look at an x-ray when someone walks in and there's arthritis on both sides of the body, whether it's both knees or both hips. Sometimes they both hurt equally. Sometimes one hurts much more than the other. But this person had something called a hip resurfacing hemiarthroplasty, which is kind of an uncommon procedure. Usually when you do a hip resurfacing, there's also an acetabular component. I don't know why this was done a long time ago somewhere. It might not have even been done in the United States, but in any case, this patient over here had this cobalt chrome head that basically eroded all the way up into their superior ilium. Okay, so there's a lot of bone loss there. And then this is a CAT scan. And basically, I'll stop it right over here. So this is the sacrum. Actually, let me see if I can do it. No, let me pause this. There we go. Okay. So this is an axial CT scan, meaning that the patient is laying down, their feet are towards you. This is their stomach. This is their back. This is their right. And then this is their left. Okay. And this over here is their spinal vertebrae. These are their iliac wings. This is their sacrum. So this is the same thing that you look at on a pelvis x-ray, but these are thousands of x-rays superimposed on each other to show you a 2D representation of a 3D image. And then as we go down more towards the feet, this is that ball that we saw, that hip resurfacing. But what I want to show you here is how thin the bone is over here. And that's almost nothing there. And then this is the medial wall of the acetabulum. And then actually on this side, this is the true pelvis. So the bladder, your intestines, all that other stuff is right on the other side of this. So you can imagine that when you're planning for an arthroplasty, you have to be very, very careful depending on what the bone stock is or what the bone quality is when you're doing this, surgery. So what we actually did for this guy is we templated again. to go back to the first question, I don't know if it was Nicole that asked, someone asked, or maybe Sydney, but about, you know, what if the components aren't fitting the right way, and what if, you know, if something seems very wrong. This is a situation where you would go in with a standard acetabular cup and you'd be like, wow, it's not fitting. Something's wrong, because you have all that bone loss. So we templated it a stem, and we actually sent overseas for manufacturing something called a custom tri-flange cage, which is it's manufactured specifically for this patient based on their CT scan. They build it, and all the screws, everything is manufactured to fit only this patient's pelvis. And then this diagram, they send it to you. This is what it's supposed to look like. You can imagine the amount of exposure that you have to get. And that's what it looks like when you put it in. So this is something called a tri-flange revision. This is about as complicated as it gets for arthroplasty. And I did this on Friday, and I actually have another one tomorrow. And this patient can walk. You know, I talked to him this morning. He's doing great. So that's kind of a little bit of a taste of joint replacement and trauma. So I guess we can kind of talk. We can answer some questions if you guys want. Or
yeah, I had a quick question. That was awesome talk and very interesting case. Thank you so much for sharing. Okay, so this, I mean, that's crazy. So if so how long would it take for that the device to be made internationally and then brought back here? What if, like, during that time the previous cup erodes through the bone and then basically penetrates into the abdominal cavity?
Sure, great question. So that's a very good question. The turnaround time, boy, it's like 3 to 6 months for them to make that, depending on, you know, the manufacturer. And they don't all come from overseas, but you know, they some of them do. Depending on where their manufacturing plants are. I mean, there's some stuff in the United States. I think this one had to come overseas, though. It was Zimmer. But in any case, yeah, I mean, as a physician, you know, another thing that you have to do is you have to, you know, you're not just a technician. You have to treat the patient. So you have to sit down, talk to them, and tell them, like, hey, listen, you have a big problem. It may get worse if you do this. I would give you these precautions, meaning, you know, no high impact activity, walk with a walker or walk with a cane. It's hard to tell someone not to move or not to walk because, you know, a sedentary lifestyle has its own risks, blood clots, deconditioning, things like that. So it's a tough problem. It's a good question that you ask, but you also kind of have to use your mind as a physician to, you know, strike that balance between letting the patient live their life a little bit so that they can stay healthy, because you have to be healthy and you have to be optimized for surgery, but you also have to make sure that they don't hurt themselves, right? After some of these surgeries, like in joint replacement, the majority of the time, the patient can walk as tolerated, meaning, you know, as much as they can bear weight with their conditioning and the postoperative pain. But in some trauma cases or in some hand cases, education of patients, meaning telling them what they can and can't do, is very, very important. Like when Dr. Cott does a tendon reconstruction, you know, that patient's not throwing a football as hard as they can the next day. It's not going to go well. They're going to injure themselves and the surgery is going to be ruined. So you have to be very careful, and you have to make sure that you educate those patients. So setting expectations is very important.
I see. Thank you.
Steve, can you talk a little bit about the soft tissues? I mean, these are huge, complicated cases, and you showed great x-rays and the prosthesis in there, but what else is there that you're looking at and thinking about? I mean, we're surgeons true and true. So what else is going on, you know, when you're in this patient's body?
Sure. So, you know, when you're planning, if you kind of, I'll show you, let me see here. Maybe I don't have it. So when you're planning surgery, there's a number of things that you have to plan. You have to plan, first off, you know, if the patient's a surgical candidate or not. But once you do that, you know, getting to the hip joint or getting to the knee joint, you have to figure out how to get to that place by respecting and as little damage as possible to the soft tissue. So we have these things called approaches. And what an approach is you make a single incision, and through that incision, you find a path to the area that you want to be with hopefully as little damage to the muscle, to the nerves, to major blood vessels as possible. So if you're going to do a hip replacement, I would say the two most common approaches that people use are something called the direct anterior approach or the posterolateral or posterior approach. Some people use other ones. There's the Harding, there's the anterolateral, there's a couple of variations, but the direct anterior approach is basically you're going to have an incision about that long, kind of over the anterolateral aspect of your thigh. And then a posterior approach, you're going to have an incision about the same length, but kind of over the meat of your gluteus. So those are the two most common approaches. When you do a total knee replacement, the most common one is something called the midline medial parapatellar incision, where if you feel your kneecap, the top of your kneecap closest to your hip, they're about 3 finger breaths above that, and then about 3 finger breaths or about 4 finger breaths below that to that bump on your knee or tibial tubercle. That's the incision that you're going to have. But in trauma surgery, it's a lot more complicated because you can break any part of your body. But as an orthopedic surgeon, one of the things that you get good at very quickly, very early is your anatomy. You have to become a master of anatomy. And once you master your anatomy, then you kind of use it to your advantage to get where you want to go. Other questions?
Sorry. You go ahead. Yeah, so I had a quick question, Dr. Noda. First, thanks for being here. This has been an awesome talk so far. Very, very much so appreciate your time. But you mentioned earlier after post hip surgery, they're walking out same day. So I kind of had 2 questions. One, what is the prognosis in terms of, I guess, how much physical therapy is needed in order to gain full functionality and mobility? And then 2, like what kind of lifestyle modifications are they making? Are they still playing tennis? Are they able to run? Is it more just walking, taking it easy? I guess what's the level of regaining function?
Sure. Great question. So the first one, it depends on the patient. Hip replacements. So like right now where I am, the protocol is that they do 2 weeks of physical therapy. Immediately postoperatively, a physical therapist comes to their home like 3 times a week. And then after that, they see physical therapy up to 12 weeks afterwards. Now, what I will tell you is that the very, very motivated patients and the patients that do very well, they come into your office and they may be walking with a walker or a cane, or they may not be walking with anything. And they don't need any physical therapy at all. And they're ready to go back to work at 6 weeks. Some people, they're more slow going. They have a little bit more pain issues, stiffness. They're afraid to kind of, hurt themselves. So it's a patient by patient basis, but the prognosis is very, very good. For a knee replacement, the big thing is getting range of motion back, extending your knee and bringing it and flexing it. For hip replacements, the stiffness is less of a problem. And especially with the direct anterior approach, which I'm a big fan of, patients are up and they recover pretty well. To answer your second question, restrictions. There are patients that play tennis, cycling, swimming. We say that high impact activities, it's not, I don't want to say it's not recommended, but there's more of a chance of you injuring yourself, number one. And also like you're putting a lot more stress on the joint, and this is a debatable topic. I'm working with someone right now that said, hey, I did a hip replacement on a very active person and they're playing full court basketball twice a week. Now, would all people that do joint replacements say that's okay? I think some people would be cautious about it, but the truth of the matter is, with this new highly cross-linked polyethylene and the modern implants that we have, it's people can be pretty active. The other thing is, your patient population is usually a little bit older. They're usually in their 50s, 60s, 70s. So the demands of those patients are probably going to be a little bit less. If someone had a hip replacement, I would 100% let them play tennis, swim, cycle, long walks. Running, I would be a little bit cautious about, but then again, sometimes these patients are going to do what they want anyway because they're excited and they don't have pain anymore. But usually, the Lancet called the total hip replacement the operation of the century. Patients that get total hips, they do very, very well. It's a high success rate. So, usually they're very happy.
Thank you.
Yep.
Dr. Minota, thank you again for being here. Just to wrap up, I just wanted to ask you if you could just walk us through your journey in orthopedic surgery and why you chose trauma.
Sure. Yeah, I mean, I was where you guys were, not too long ago, but it's getting, it's weird every year it gets one year more longer. Yeah, I mean, I think I made my decision to go into orthopedics a little bit later. I always thought it was cool. I always thought it was interesting. I made my decision probably around third year. I gave medicine a good shot, internal medicine, and I thought, cardiology was cool. And I did my surgery rotation and rotated with orthopedics for 2 weeks. I saw Dr. Sahabian operate, and he's the man. He's great. He was, very nice to me, and I hung out with Dr. Harwood. And these guys, they were doing complex surgery. The patients were getting better. The problems were getting fixed in the operating room, which was very encouraging. It wasn't like, we're going to see them in 3 months and hopefully they get better after we devise this treatment plan. Like the patient came in, they had a broken bone and it was fixed. So I thought that was really cool. And then, I'm sure you guys know about the match process, or if you don't, then that's another talk for another time. But once I got into orthopedics, I thought trauma was a lot of fun. You can help people. It's probably the worst day of their life or one of the worst days of their life, but you can make a positive impact, and you're not going to make them perfect. You're not going to make them as they were before they got hurt, but you're going to get them as close to that as possible. It is physical work. It is hard work. There's a lot of physics involved. There's a lot of mental planning. There's mental toughness. All those things kind of appeal to me. And then joint replacement, you can really affect someone's quality of life. You can take someone that really can't walk and is in pain all the time and really change them. I have seen people cry in the office, like after, their 6 week or 3 month, follow up, and they can't believe that, all of a sudden their pain is gone. Not all of a sudden, but their pain is finally gone, and they can walk with their grandkids again, or they can dance with their wife or something like that. So that's cool. So all those things kind of contributed to it. And, I don't know, I just thought it was of all the other fields, I couldn't see myself doing anything else. And this was the coolest one. So.
All right, thank you. Any other questions? All right.
Dr. Cott, you have anything else you want to add?
Just that you are the man. Every time I hear you talk, you are absolutely the man. And for those who don't know, Steve, we're so lucky he's joining our practice. So we can't wait. We're going to open his schedule as soon as we possibly can. So what is it? September, you're going to be down with us?
Something like, by the way, also, just so you know, this is seltzer that I'm drinking. I'm not drinking beer talking to you guys. So, but yeah, no, I'm fortunate enough to be joining Dr. Kott's group, Orthopedic Institute, Brielle Orthopedics. I'm going to be jumping in September. So I'll be in the area, and hopefully, I know I talked to some of you about. I know there's an anatomy lab going on, I think in May or in June or something. I can't make that one. But as time goes on, as my once I figure out what my schedule is actually going to be, I'd love to help you guys out when I can. Obviously, as things kind of change around, but good luck. If you have questions, reach out to the residents. And it's a fun journey.
Thank you again. And thank you,
All right,
Dr.
guys.
Kopp, for being here. Appreciate it.
Take care.
Everyone, have a good night.
Thank you.
All right.
Bye.
Well, I guess I'll end it, but cool. Yeah, I think that's about it. So, hi, Daniel. Yeah, so that was good. I think.
All right. I guess we'll talk later.
Yeah, we'll talk on the weekend maybe when we have some
Okay.
time.
Sounds
All
good.
right. See you later.
Bye.